I'd like to let you know that Aussie MedEd is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, as well as HealthShare's Specialist Referrals Directory, a specialist and allied health directory helping GPs find the right specialist. The key to medicine is making a diagnosis. For us, a diagnosis that not only helps us to explain to the patient the cause of their symptoms, but also allows us to give a prognosis and offer treatment options. Well, the key to a diagnosis is the history, examination, and performing investigations. Unless you know what you're looking for, choosing from a selection of diagnoses can be challenging, and you won't be able to come up with an appropriate treatment plan. People in the past have used surgical mnemonics to try and remember the various options for making a diagnosis, but these can be quite complicated. I previously taught about using the rule of threes to divide things into simple categories. This works well for hips and shoulders, but how does it work for hands, with so many different medical conditions? Today, we're going to go through this and explain it, and at the end, I will show you how this will make assessing a patient with a musculoskeletal hand condition much simpler. Welcome to Aussie MedEd. Good day and welcome to Aussie MedEd, the Australian medical education podcast, designed with a pragmatic approach to medical conditions by interviewing specialists in the medical field. I'm Gavin Nimon, an orthopaedic surgeon based in Adelaide, and I'm broadcasting from Ghanaland. I'd like to remind you that this podcast is available on all podcast players and is also available as a video version on YouTube. I'd also like to remind you that if you enjoy this podcast, please subscribe or leave a review or give us a thumbs up, as I really appreciate the support and it helps the channel grow. I'd like to start the podcast by acknowledging the traditional owners of the land on which this podcast is produced, the Kaurna people, and pay my respects to the elders both past, present and emerging. We may have seen my prior podcast on the rule of threes and how it can help you in medicine. In that, I talked about why dividing things into threes can be so useful, and the number 3 seems to repeat itself throughout life, literature, and in famous speeches. I use it all the time in medicine. If you think of 3 as the most common number, then using a Gaussian distribution, you can think about the rule of threes, involving the rule of 2s, 3s, 4s, or even 5s as a simple way of dividing things up. In my podcast on shoulder conditions, I explain how this method can not only help you remember the various diagnoses, but also make it as much simpler in assessing a patient and offering treatment options. Students, however, have asked me whether this can work in the hand because there's so many different things that can occur in the hand. The answer is yes. It gives us a structured approach. Let's break it down. If we think of hand presentations as either being traumatic or elective, with traumatic presentations being those that may present to an emergency department, and elective cases being those seen in a clinic, this is a starting point. Now, the third type of presentations, which are not quite as common in hands, are the mixed picture, those elective type conditions that really have commenced after trauma. Now, I'll start off by saying this doesn't cover every possible diagnosis. From my experience, however, it does cover 90% of the common things that I see as a hand surgeon, and I hope it can be a good starting point for you to build upon. Let's start with traumatic conditions. My mantra is that traumatic conditions typically involve fractures, dislocations, and infections. But when it comes to the hand, we also need to consider tendon injuries, those being lacerations or avulsions of the tendon, as well as nerve injuries. Therefore, if we categorize the 5 main traumatic hand conditions, we have fractures, dislocations, infections, tendon injuries, and nerve injuries. Let's start with fractures. When thinking of fractures, we'd start with the bones involved, that being the distal radius and ulna, or the carpal bones, or the metacarpals and phalanges. If we look at the distal radius and ulna, we focus on the radius as this is the main bone involving the wrist joint. These can be extra-articular, and the 2 well-known ones are Colles fractures, where there's dorsal displacement of the wrist, or Smith's fracture, where there's volar displacement. Well, the fractures can be intra-articular, such as Barton's fracture, which is a volar intra-articular fracture, where the volar fragment is displaced volarwards along with the carpus, as well as a radiostyloid fracture. We can have grossly comminuted intra-articular fractures. These fractures may or may not have a distal ulnar fracture with it. If we go on to the carpal fractures, the most common and concerning fractures are scaphoid, which can occur after a fall on an outstretched wrist. It can also occur after using a drill, when a drill bit gets caught in the masonry and the hand twists. So the scaphoid is an important injury, and due to its poor blood supply, this can lead to non-union secondary to avascular necrosis. And later, it can lead to arthritis if the fracture has been missed. Other carpal bones can also be injured as well, including the triquetrum, which is a common injury, often seen on the lateral X-ray, as the ligaments avulse the fragment of bone off the dorsal aspect of the triquetrum. This is really a type of wrist sprain with an avulsion of the dorsal ligaments. If we move on to the metacarpal and phalangeal fractures, metacarpal fractures often involve the neck of the bone. This is one of the more common ones, is known as a boxer's fracture, where someone punches something like a wall and the fifth metacarpal neck volar flex. Fracture can also occur at the base of the metacarpal. This can be like a fracture dislocation pattern where the bones try and subluxate on the carpal metacarpal joint and fracture at the same time. Fracture at the base of the thumb are also common. And one that's important is known as a Bennett's fracture, which is intra-articular, where the fragment stays with the ligaments and the rest of the bone subluxates radialwards. You can also get fracture of the whole base of the thumb as a Rolando fracture, and these can lead to instability and secondary arthritis. Phalangeal fractures involving the distal phalanx are common and often quite simple, but the phalangeal fractures can be more complicated if they involve the joint surface, particularly around the PRP joint. When looking at dislocations of the hand, these can occur at any of the joint levels, including carpal dislocations, where you might get a dislocation of the lunate bone or the bones around the lunate called perilunate. And these are considered surgical emergencies because the bones then push on the median nerve and can lead to compression of the nerve and also vascular compromise. Because of the number of bones involved in the carpus, it's often difficult in interpreting x-rays, and they can be easily missed. It's important you're aware of them and check for the 4 C's on lateral extraorbital wrist, that being the distal surface of the radius, the proximal surface of the lunate, the distal surface of the lunate, and the proximal capitate. And these 4 C's should all line up on the lateral x-ray. These dislocations can be associated with carpal fractures as well, such as the scaphoid fracture when you get trans-scaphoid perilunate dislocation. I'd like to let you know that Ozymed is sponsored by OPC Health, an Australian supplier of prosthetics, orthotics, clinic equipment, compression garments, rehabilitation devices for doctors, physiotherapists, orthotists, podiatrists, and hand therapists. If you'd like to know what OPC Health offers, visit opchealth.com.au and view their range online. We move on to the metacarpal phalangeal joints and interphalangeal joints. These dislocations are particularly common on the sports field and are often reduced by trainers. We need to be aware of them as well and lead to result in swollen hands. Associated with that, you can get a avulsion of the volar plate that stops the PRP joint hyperextending, and that's called a volar plate injury and often pulls off a fragment of bone with it. 2 important other ligament injuries are the gamekeeper's thumb, also known as the skier's thumb. The thumb, when someone falls on the hand and the thumb is forced into radial deviation, tearing the ulnar collateral ligament of the metacarpal phalangeal joint, and this can lead to instability of the thumb. This injury is important because the ligament comes away from the joint and actually subluxates outside of what's known as the adductor aponeurosis and doesn't sit back next to the bone in many situations, not all, and that can lead to chronic instability of the thumb and pain and secondary arthritis. The other injury is the scaphoidal ligament injury, which is a similar injury to fracture of the scaphoid and really is a minor version of a carpal dislocation that we discussed earlier in the start. And really, given that the ligament itself can't be seen on x-ray, it's often missed. And people are more concerned about scaphoid fracture, but it should be similar to a scaphoid fracture in that it can result in chronic pain and development of arthritis later in life. This is one of those conditions that's a traumatic presentation leading to an elective condition, and we'll go into that in further detail later. Infections of the hand can involve bones, joints, or soft tissues. Infections of the joints are called septic arthritis, and the infections of these areas are also considered a surgical emergency. One type of infection that should not be missed is what I call a fight bite, where a laceration occurs over the knuckle, someone punches someone in the face, leading to a cut over the metacarpal phalangeal joint. And during this time, where she enters the joint, introducing oral bacteria into that joint. But each time there's a tooth wound over a knuckle, it should undergo a full washout of the wound in surgery. Flexor tendon sheath infections are also quite important because this is another orthopedic measure because the flexor sheath infection can lead to result in scarring, which leads to stiffness. And because it's a localized compartment, the issue of all localized compartment syndrome associated with it. Therefore, if it's not washed out early, it can lead to a very poor function of the hand later on. This brings us into tendon injuries. Tendon injuries often result from lacerations or avulsions. Extensor tendon injuries may present a simple inability to extend the finger, with the common one being a mallet finger, which is an avulsion of the extensor tendon on the distal phalanx. The equivalent injury to the flexor tendon is known as a jersey finger and may result in loss of flexion. The former one is treated with a simple extension splint, while the latter requires surgical repair. If we get on to nerve injuries, these are critical in hand trauma, particularly when they're caused by lacerations. Early assessment and repair of nerve injuries are crucial for recovery, And nerve injuries can be classified using the Setting classification or the Sunderland classification. The Setting classification is easier and, ironically, is divided up into three main grades: neuropraxia, actinomesis, and neuromesis. Compression injuries, such as those caused by lunate dislocation or from other bones, but fracture, lip, push-out, or median nerve, can lead to acute symptoms as well, requiring immediate intervention. All right, well, they're the main traumatic conditions. What if we move on to elective hand conditions? The elective issues are those that don't require an emergency trip to a hospital, but definitely require attention in the clinic. We can divide these into 5 key areas as well: joints, bones, tendons, nerves, and ligaments. Plus, we've also got an extra category for those conditions that don't quite fit in anywhere else, like tumours and miscellaneous conditions. If we look at joint conditions, first, let's talk about one. When it comes to the hands, arthritis is the real big one. There are a few main types we commonly see of arthritis. I like to divide these into 3 main areas. Primary osteoarthritis, this is the wear and tear variety, often from repetitive use or degeneration over the years. The more common area, obviously, in the hand is the interphalangeal joints, where it's associated with deformities, particularly seen in middle-aged patients, and with the developments of Heberden's nodes at the DRP joint and Bouchard's nodes at the PRP joint. These are just osteophytes producing a lump at those joints. It also commonly affects the base of the thumb and the carpal metacarpal joint, leading to carpal metacarpal arthritis, or the region just below that, the scaphotrapezial trapezoid joint, STT joint. These lead to pain and reduced grip strength and functional limitations. While primary osteoarthritis, the risk can occur, it's more commonly secondary to trauma, including ligament injuries, damage to the joint surface, post-inflammatory or metabolic disease. That brings me on to secondary osteoarthritis. This type usually follows previous trauma with damage to the chondral tissue or incongruity of the joint surface. It also can relate to post-inflammatory conditions such as rheumatoid arthritis or gout, etc. Then we get our third type, and obviously this is a quite encompassing area, the inflammatory arthritic conditions. This covers conditions like rheumatoid arthritis and other inflammatory arthropathies, and these are systemic in nature, affect multiple joints, as well as other tissues, including tendons, leading to deformities like ulnar drift or swan neck deformities, etc. We've covered this a lot previously with an interview with Sam Whittle on the podcast. Now, any of these types of arthritis can lead to the production of fluid. Injuries anywhere can lead to the production of fluid, including soft tissues and tendons, but what's more common in joint surface and particularly in arthritis, and this produces cysts that occur near the joints of the fingers or the wrist. This is what's known as a ganglion, but near the DRP joints, we call these lesions a mucus cyst. If we look at bone conditions, well, the most common bone issues probably are tumours or bone cysts, and this we covered in a separate podcast. Another bone issue, which you may not have heard about, but which is worth knowing about, is Kleinbach's disease. It's avascular necrosis of the lunate, which occurs spontaneously. We look at it on X-ray. Initially, you might not see much, but then you might see some sclerosis as the bone becomes avascular. And then you might see signs of the part of the joint collapsing, leading at secondary to the avascular necrosis, and that can eventually lead to arthritis. It's rare, but it's worth knowing about. Moving on to tendon conditions, well, tendon problems are pretty frequent in the hand with conditions like trigger finger and decurvatus tenosynovitis. Trigger finger happens when the tendon enlarges and gets caught in the tendon sheath or flexor sheath, causing the finger to lock. And the patient might have trouble flexing the finger down because it's catching just proximal to the A1 pulley in the flexor sheath on the palmar side. Or once it does flex down, they might not be able to straighten it out, and suddenly they have to force it out straight, and they hear a click as it does. Decurvatus tenosynovitis is a similar condition of this. It involves inflammation on tendons on the radial side of the wrist, the first extensor compartment, often with secondary repetitive thumb movement. It's very commonly associated with a newborn child or from lifting it up. People usually report pain when gripping or twisting, especially around the first dorsal compartment over the radial styloid. You can get tendonitis in other areas too, such as intersection syndrome. We get pain on the dorsal wrist where the EPL tendon, extensor pollicis longus, crosses over the second extensor tendons, extensor carpi radialis longus and brevis, causing pain. And you also get tendonitis in the fourth extensor compartment, that involving the extensor digitorum and indicis with associated pain and crepitus. Tendonitis can happen just about anywhere in the hand, and it's often associated with swelling and crepitus when the tendon moves. We move on to nerve conditions. Well, nerve issues occur in the hand are pretty well known, with carpal tunnel syndrome being one of the most common diagnoses made. Carpal tunnel syndrome occurs when the median nerve is compressed in the carpal tunnel, leading to numbness, tingling, and weakness of the thumb, index finger, and middle finger, and half the ring finger. It's often worse at night, or with repetitive wrist movement. The patient often needs to get up and shake their hand around. They often find it worse when holding a phone or riding their bicycle. You can get similar symptoms affecting the ulnar nerve as well, with paresthesia affecting the ulnar nerve, the little finger and half the ring finger. The ulnar nerve compression can occur in the Guillaume's canal of the wrist, just superficial to the flexor retinaculum, or the cubital tunnel behind the middle aspect of the elbow. Patients again will report tingling and numbness in the ring and little fingers and make it tough to perform precise movements. With carpal tunnel and cubital tunnel syndrome, it's always a good idea to rule out any cervical spine issues, as nerve compression further up could be a part to play. As we mentioned previously, nerve entrapment can be a complication of acute traumatic condition. Then we get ligament injuries. Ligament injuries can occur electively, chronic stretching, or secondary to ligamentous laxity, but a more common scenario is a chronic presentation of a prior acute injury. An important type of ligament injury is the scaphoidal ligament injury, secondary to trauma, but with delayed presentation. This is what we discussed earlier, but when left untreated, these can lead to scaphoidal advanced collapse, which can cause long-term instability and lead to secondary arthritis in the wrist. Patients often reporting a clunking feeling when they're gripping or loading the wrist, and then they get pain. Scaphoid fracture non-union can also lead to this scenario as well. This is known as scaphoid non-union advanced collapse. Another traumatic ligament type injury is an injury to the distal radial ulnar joint and the triangular fibrocartilage. The triangular fibrocartilage is a soft tissue that fixes the radius from the edge of the radius to the tip of the ulna, what's known as the ulnar fovea. And as the hand supinates and pronates, the radius swings around the tip of the ulna along this soft tissue envelope. In acute injuries, but on falls, when the ulna doesn't fracture, this ligament can tear. It often tears as we age anyway, and it's part of the degeneration, and that's where chronic conditions of these can occur as well. This is where patients will present with ulnar-sided pain and difficulty with supination and pronation of the wrist, and it may cause a clicking sensation. And this is something to keep aware of as well. Finally, we move on to those miscellaneous groups of conditions that don't fit neatly anywhere. These include benign and malignant tumours and congenital issues and certain soft tissue problems. I intend to discuss tumours in a later podcast, but I think there are two conditions worth knowing about. The first is Dupuytren's contracture. This is a genetic condition where the palmar fascia thickens, leading to gradual bending of the fingers, particularly the ring of little fingers. Over time, this makes it difficult to fully straighten the hand out, and the fingers get stuck in the palm as it slowly gets worse. Once you've seen a Dupuytren's contracture, it's pretty obvious. Giant cell tumour of tendon sheets, another benign type of tumour, which is a nodular growth on the tendon sheet. It often looks like a ganglion, but tends to be firm and doesn't fluctuate in size like ganglions do. So there you have it, a rundown of hand conditions, which from my perspective, I would qualify this by saying this is my opinion. It's a simple way of thinking about the conditions. I'm sure there are other conditions that may have been missed. This covers 95% of the common conditions. This breakdown can help keep things straight when it comes to diagnosis and management, making it a bit easier to narrow down the options when a patient comes in with a hand complaint. With this approach, you're better positioned to understand what's going on and, more importantly, how best to treat it. I hope this simplifies things when you're faced with the hand cases to assess in a clinic. The last thing I'd like to talk about is the symptom-based diagnosis in hand conditions. The most important thing is that they present with specific symptoms which can guide the clinician towards the most likely diagnosis. By focusing on these key clinical presentations, which involve pain, deformity, neurological symptoms, instability, and lack of motion, clinicians can quickly narrow down the differential diagnosis and determine the best course of action. Let's look at each of these symptoms and how they can help target specific diagnoses. Starting with pain, it's a common symptom both in traumatic and elective presentations, and often the primary reason patients seek medical attention. The location, type, and duration of pain can provide critical clues. In traumatic injuries, pain is usually acute and directly follows an event such as a fall, blow, or a cut. Faced with a diagnosis of a traumatic scenario presenting with pain, options usually are fracture, dislocation, or infection. Nerve injuries and tendon lacerations are less likely. Localizing the pain can direct you towards where you need to direct the investigation, of which the most important one would be an X-ray. The presenting case of a traumatic pain is less likely to be an acute nerve injury, and whilst a tendon laceration or injury can cause pain, it's more likely to present with loss of motion, and the story also will give it away. Likewise, with elective presentation of pain, arthritis and tendonitis are the most common diagnoses for the possible rare presentation of avascular necrosis or instability. Once again, the site of pain can help you assess where the condition is arising, and if associated with crepitus, the site of origin will also assist. In primary osteoarthritis, patients may experience a deep aching pain, while conditions such as the quervated tenosynovitis will cause pain when the tendon is stretched or moved. For the latter, if X-rays have excluded arthritis, an ultrasound can confirm the tendonitis. Another presenting symptom might be deformity. Visible deformities are more common in traumatic hand conditions, but may also appear in advanced stages of elective conditions. With traumatic deformities such as angulation of the metacarpal, such as a boxer's fracture, or and dislocation of the metacarpal phalangeal joint, are usually easily seen, whilst the inability to extend or flex the joint suggests tendon injury. In an elective scenario, rheumatoid arthritis can lead to the classic deformity, such as swan necking and boutonniere deformities, but these may develop over time due to joint and tendon involvement, but actually due to the advances in rheumatological management, actually quite rare nowadays. For a patient presenting with deformity, X-rays are usually the initial investigation, with an ultrasound being a close second. But if you're suspecting an inflammatory pathology, don't forget to order blood markers for rheumatoid arthritis. As I said before, patients with Kupfer's contracture work on progressive flexion deformity of the fingers, particularly at the ring and little finger, due to palmar fascial thickening. And the thickening of the palmar fascia is really quite obvious. Neurological symptoms such as numbness, tingling, or weakness are often pointers towards nerve compression or injury. These symptoms can be seen in both acute traumatic conditions as well as chronic compressive syndrome. The trick here is to diagnose the correct nerve affected and exclude other causes such as cervical radiculopathy. The appropriate investigation here would be nerve conduction studies, and I've recently done a podcast with Jessica Hafner on peripheral neuropathy. Instability or joint or ligament instability can be a sign of both traumatic and elective conditions, often leading to recurrent injuries or long-term dysfunction. This is where X-rays will help diagnose chronic pathology consistent with elective presentation of instability with developing secondary arthritis, whilst ultrasound or MRI scan may help with ligament injuries. Sometimes, however, all these investigations are not that helpful because it may be dynamic, and certainly a good examination is one of the best ways of assessing it. And this is particularly important when looking at distal radial ulnar joint instability of the distal ulnar. Patients finally may present with lack of motion due to both joint, tendon, or soft tissue pathology. Both traumatic and elective conditions can lead to restricted movement, with fractures or dislocations being the most common traumatic cause for loss of motion, secondary pain, and an X-ray making a diagnosis. While selectively, the most common cause is arthritis, and getting an X-ray will be the first investigation. In conclusion, while evaluating hand conditions, the combination of symptoms such as pain, deformity, neurological deficits, instability, and lack of motion can help narrow down the diagnostic possibilities. However, having a system to offer the possible diagnoses is extremely valuable. Therefore, the presentation of either a traumatic or elective presentation, knowing anatomy, and understanding the patient's symptomatology provides essential clues for accurate diagnosis and optimal management. By systematically assessing these symptoms, I hope this can help tailor the physical examination and investigations to arrive at the most appropriate diagnosis, ensuring timely and effective treatment for patients with hand conditions. Thanks for listening to me with Aussie MedEd. I'd like to remind you that all the information presented today is just one opinion and that there are numerous ways of treating all medical conditions. Therefore, you should always seek advice from your health professionals in the area in which you live. Also, if you have any concerns about the information raised today, please speak to your GP or seek assistance from help organisations such as Lifeline in Australia. Thank you very much for listening to our podcast today. I'd like to remind you that the information provided is just general advice and may vary depending on the region in which you are practicing or being treated. If you have any concerns or questions about what we've discussed, you should seek advice from your general practitioner. I'd like to thank you very much for listening to our podcast, and please subscribe to the podcast for the next episode. Until then, please stay safe. I'd like to let you know that Aussie MedEd is sponsored by Avant, Medical Legal Indemnity Insurance. They tell me they offer holistic support to help the doctor practice safely and believe they have extensive cover that's continually evolving to meet your needs in the ever-changing regulatory environment. They have a specialist medical indemnity team located here in Australia and have access to medical legal experts 24/7 in emergencies.